So thank you so much for this great presentation. And actually the idea was that after these three excellent talks that we will have roughly 15 minutes for discussion. So allow me to take advantage of my being the chair, and actually, Mark, I would like to ask you, one of the major problems that we are facing now during the COVID is a situation and inflammation of the gut of the patients and a lot of diarrheas, and many of patients with long COVID. They seem to present with symptoms compatible with IBS-D. And actually, we have shown both your cohorts and our cohorts that, and you presented the data, that there is expression of the cytokines in the lumen of IBS. So what is your impression of whether the long COVID patients are facing? It will be an IBS-like or an IBD-like phenotype in the near or short or long-term future?
You know, it's really hard to know. Dr. Rizai, one of my other colleagues, in collaboration with Max Schmulson in Mexico and other folks, have recently just now published a paper showing that IBS seems to develop after functional GI disorders are common in the long COVID patients. Whether it's due to a change in the microbiome as we're seeing here, it's not due to CDTB, because CDTB is not present in patients. It's not present in these viruses, so it may be another mechanism, and maybe there's some kind of enterotoxicity that occurs, or autoimmunity, which we know can happen after COVID, because there are a lot of cases of autoimmune diseases that are precipitated.
Okay, Gabriela, thank you for the fantastic presentation. I believe that everyone who attended is sure that it's quite different that studying microbiome in the fluids than in the stool. So what about the biopsies? Do you have any kind of data showing if there is any correlation about the microbe attached to the mucosa with the microbe in the fluids?
Thank you very much for a question. Very interesting question. Actually, I did not present one of these slides. I was planning to show you a little bit of our data on the mucosal microbiome. This is something that we do as well, and we are so fortunate because as we collect the aspirate from these patients, we also collect biopsies. So we had the opportunity to compare the microbiomes, the luminal microbiome with the mucosal microbiome. And as expected, as we see in the column as well, they are different. So they share a lot of features for sure, but what we do know about the mucosal microbiome, we have a little bit more higher diversity. Most of the, at least at genus level, that's something that we still like working on the mapping step. So we still do 16S sequencing. So not talking about specific strains or species. So they do share most of these genus, but at different levels. So yes, it is different. It's something that we are working right now. It's a little harder to study because when you study the microbial population, the mucosa, you have so much more human DNA than microbial DNA. So I think the most challenging step is to separate these two sets of DNAs and be able to do a high deep sequencing with confidence. And this is something that we are doing right now. So, but stay tuned. Soon we will have a paper on it. Thank you so much for your question. Very good.
Thanks. And if I may ask Dr. Mathurio, you have published some very, very innovative papers about the role of obesity and especially methanogens, the correlation of methanogens abundance and the presence of obesity and obesity-related disorders. So is there anything new on this field brought outside from the Reimagine program?
Again, a very good question, Kostas. Your timing is impeccable. We're actually right now in the process of analyzing some new data from our reimagined cohort and putting that in a paper for obesity. So I can't say anything now. Dr. Leite has all of the data on her desk, and she is actually doing the analysis as we speak. So hopefully there'll be some new information, not just on the archaea and the methanogens, but also on specific bacterial profiles in obesity as it pertains to the small bowel. The interesting thing about methanogens, as you know, is that, as Mark has already alluded to, the presence of methane slows the gut down. So the question is whether or not that slowing is actually making it more time for a nutrient absorption in the intestinal tract, and whether that's one of the ways that the calorie harvest is occurring, or whether there's other properties such as inflammation and other things that are going on. And so we are working on that right now, and Dr. Leite is actively looking at that data. Thank you for your question, Costas.
Okay.
May I address a question, which actually, I don't know whether it is a naive question or hard question, and Mark, the question goes to you. Based on all that we have listened about the modulation of the diversity of the microbiome and actually this down-regulation, let's put it this way, of or the lack of diversity in patients with IBS. Do we honestly believe that treating with probiotics can change the phenotype?
That's a very tough question. We have some information on that, but let me just, before I jump to the probiotics, highlight something we see in the Reimagine study, because we have some patients who have done the microbiome analysis and then returned some months later for another endoscopy, and we see later. And I can show you an example, but I don't have the slide handy, where they took rifaximin, and their microbiome diversity improved after rifaximin. And so by getting rid of E. coli and Klebsiella, which are suppressing the microbiome around them, the microbiome is allowed to flourish. So the challenge we have with probiotics is when you administer a single or two microbes, you could be suppressing the normal microflora by being so limited in what you're providing. Hence fecal transplant. I mean, we now know fecal transplant works better because it is the complete composite of the microbiome rather than a single organism. But having said that, we don't think probiotics are necessarily unhealthy in healthy individuals, but we need to know more about what's happening with probiotics in the small intestine. And that's what you'll hear more of later this year, because everybody has looked at stool so far, but in the small intestine, the dynamics of probiotics are potentially unfavorable, as you'll see later this year.
Thank you.
Right. I was astonished when I saw your presentation, Gabriela, regarding the study published with first name with your colleague Maria Milan about the abundance of methanogens, of methanogenic flora in the different parts of the human gut. I remember, I'm sure that Mark also remembers that while I was in Los Angeles, we reviewed the results of, we coupled 3 studies in animals where we reviewed the topography of methanogens in normal rats. And interestingly enough, we found exactly similar results. And at that time, we were wondering what is Methanobrevibacter smithii doing in the duodenum. And now you know better, and you know you have new information, and this is, in my opinion, it was fascinating. Probably it was a small study, probably people did not also understand that we didn't manage to publish it. Anyway, but I send my congrats to to Maria Milan. And Mark,
Sure.
I'm sorry, yep, Richie or Gabby?
I was saying that I will send her your.
And Mark, I think a couple of years or last year, you published a paper about that the number of patients visiting the hospital with IBS is declining. And
yeah, so
how can you explain that, and what do you think in the future?
So I think the paper you're referring to is the fact that since rifaximin has been available, the number of patients being referred to tertiary care for IBSD has gone down dramatically in the US. That's a good thing. I mean, because tertiary care means more health expenditures. So primary care gastroenterologists, even primary care internists are now treating IBSD, at least with rifaximin early in their course. And this results in less colonoscopies, less healthcare utilization and cost. So that's been a great benefit. But I do want to go back to one thing about methanogens, and this bridges, again, Greece and Los Angeles, because we've done some amazing things together, and maybe people don't realize how impressive these results will be in time. For example, with Evangelos, we did find that methane and methanogens are associated with lower TNF in the secreted fluid in the gastrointestinal tract, and we continue to see that IBD patients don't have methanogens. So what I'd like to sort of suggest is that we shouldn't look at methanogens as bad or good, or any organism as bad or good, but rather that the methanogen has to be at a specific level to perhaps suppress your immune system, not too low and not too high. Too high means constipation. Too low perhaps is a risk factor for IBD, if I could postulate that. We don't have data yet, but it's a very interesting postulate given the data we have so far.
Okay, now I would like to ask Dr. Mathur to give us some more information regarding the Reimagine program. For us, which are very naive to that, it looks something amazing. I mean, it's something far in the space for our practice or for our science. So can you please share with us how the program started, how it was, how it's evolving, and what do you envision in the near future?
Sure. And actually, once again, we have a Los Angeles Greek connection here, because some of the data that we have was initially collected by your team. So we're very grateful for that. And that kind of was the nidus for starting some of this work way back. So these are samples that are obtained from our gastrointestinal colleagues here, particularly at Cedars-Sinai, but we welcome collaborations from across the globe. These are samples that are obtained under sterile conditions in non-colon prepped patients. So these are patients that are coming in just for an upper endoscopy. We have a team of patients, a team of doctors that will do upper endoscopy, either simple endoscopy or double balloon, through a validated technique. And essentially, it allows for us to make sure that there's very little upper contamination. So we know that the samples that we're getting are specifically from the small intestine, the area where we're wanting to get the samples from, and we biopsy from them. And in addition, as I mentioned, there's a whole slew of anthropomorphics that we get on these patients, a number of questionnaires, at least an hour or so of questioning the patient's dietary history, socioeconomic history, and so on, severe and illness history. We get medication history. So it's a composite of a number of parameters that we get. Blood work that we archive so that we can run them in batches for everything from glucose and insulin all the way to cytokine profiles. So it's a fairly elaborate setup to get all of the information together. It then is all processed. And what we do is we try to extrapolate one disease state. So suppose we have a sub-cohort of patients that have rheumatoid arthritis. We can pull those out of our data set, take a look at their microbial fingerprint in the small bowel, and see what pops out. What's different in that cohort, that group, compared to those that don't have rheumatoid arthritis? And can we find a signature that we want to target? We then have to take out all of the other things that might be confounders that I talked about, the smoking, the aging, all those things, take all of those out, and then we're left with the microbes of interest that we can either manipulate or target specifically. Once we get those microbes of interest, we go through Koch's postulate. They're put into animals. We try to create a phenotype in the animal. We try to see if we can get rid of the phenotype in the animal. So it's a whole process that we do. We're very excited about it. At this moment in time, we have about 600 subjects that we've completely analyzed. Our goal is to get into the thousands so that we can fingerprint as accurately as possible.
So thank you, but I feel that the time is going by, and you have work to do. You have the whole day ahead of you. It's early in the morning in Los Angeles, and Evangelos, the microphone is yours for the farewell.
Thank you really very much. That was really great being with you, spending such a fascinating last hour with you. Thank you really very much. And the most important thing is that you motivated all young colleagues. We have a really enthusiastic and young audience today with us. Also, you gave for us, for the older ones, a lot of new knowledge, but I believe the most important is that this is also what you have done for us today, a trace of our continuum, of the continuity of our collaboration. And both myself, Kostas, and all our society are really thankful to you. Thank you very much.
Bye-bye.